Renal cyst. So we shall be discussing two important renal cysts, which is your autosomal dominant polycystic kidney and your Bosniak cyst classification of your renal cyst. So let's begin our discussion with your autosomal dominant polycystic kidney. Now it is your most common autosomal dominant genetic cystic renal disease causing your chronic renal failure, requiring your dialysis and your renal transplantation. It occurs due to the mutation of PKD1 gene, which is situated on chromosome 16, and PKD2 gene, which is situated on your chromosome 4. Now 50% develop end-stage renal disease. Now what are your risk factors causing your end-stage renal disease? So you have your early age of presentation, hypertension, male sex, ADPKD gene 1, and African ethnic group. Now it has your various association of cysts in your liver, arachnoid membranes, seminal vesicles, and your pancreas. Then intracranial aneurysms are associated in around 10 to 30% patient of your autosomal dominant polycystic kidney disease, and SH may cause sudden death in the patient. So you should remember this associations because your clinical scenarios might be formed where they would be giving you a hint of your SAH in such patients. So you need to remember that intracranial aneurysms are associated in around 10 to 30% of patients with your autosomal dominant polycystic kidney disease. Now moving down to the next is your renal cyst, which is your Bosniak cyst classification. Now this is on the basis of your malignant potential of your cystic lesion. So all I would want you all to remember is this few particular points with respect to your renal cyst. So if you look at your first image, so it has, this is the simple cyst over here. It has no septa, no calcifications, no solid components, no enhancement, right? So this is your Bosniak cyst classification type 1, which is around 0% malignant. Now we look at the next. So if you look over here, you have a few hairline thin septa, which is around less than 1 mm, and it has thin calcifications and it is well marginated. So again, this has your 0% risk of malignancy. Now if you look at this third image, you find that it has your multiple hairline septa, which are again well marginated. They do not have any enhancement and have a high attenuation lesion, which is around more than 3 centimeter, and it is totally intrarenal. So this are risk of around 5% malignancy. So what you need to do in this patient is that a follow-up at 6 months, 12 months, and your 5 years. Then we have your this cyst, which has thick, irregular or smooth wall or septa, and it has a measurable enhancement in your CT scan. So the treatment for this would be a partial nephrectomy or a radiofrequency ablation if the patient is a poor surgical candidate. Now if we look at this last, which is your category 4, you find that you have your thick, irregular or smooth wall septa, which has a measurable enhancement just like your stage 3, but at the same time it also has a lot of enhancing soft tissue components adjacent, which are independent of the wall or septum. So this is your stage 4, again where your treatment would be your surgical treatment. So please remember this Bosniak cyst classification. You might be getting an image and asked regarding like identify the type of your cyst, or at the same time you might be given a clinical scenario where your CT scan findings are given and then you need to diagnose. So this is all with respect to your renal cyst disease, the autosomal dominant polycystic kidney disease, and your Bosniak cyst classification. Thank you.